Good afternoon, everyone. My paper is on analysis of respiratory diseases and drugs used for treatment in the perspective of hypokalemia ADR development. As all of us know, hypokalemia means serum potassium levels less than 3.6 millimole is considered as hypokalemia, and both outpatient and inpatient can have this hypokalemia. So, what are the causes? It can be due to altered physiological changes or use of medication, diseases, and coexisting diseases, abnormal losses, low intake, and transcellular shift. So, why should we worry about this hypokalemia? Hypokalemia increases the myocardial excitability and it can induce ECG changes. More mild to moderate hypokalemia may not have any signs or symptoms, but it can rebound with severe consequences. And also, it is proved that cardiovascular diseases and in long-term kidney diseases, mortality will increase because of hypokalemia, and deaths are also increased. My objective is to analyze the drug-disease interaction development of hypokalemia ADRs with respect to respiratory diseases and drugs used to treat these based on the available literatures. So, ethics committee approval was taken to collect the data. Basically, the data collected as per the Pharmacovigilance Program of India was utilized for conducting this study, and data was collected from November 2016 to October 2017, and our inclusion exclusion criteria was any patient suffering from hypokalemia who were admitted inside the hospital while treatment, they were considered, but others were excluded. Data collection, as I said, ADR forms were utilized for collecting the data, and it is exactly as per the PPPI program. The data was collected, and mild, moderate, severe was classified based on the serum potassium levels as it is given. Statistical analysis was done using Instat software. 60 ADRs were analyzed for like 60 patients who had hypokalemia were analyzed, and equal number of male and female were suffering from hypokalemia, and body weight and other things were calculated just for the clinical interpretation. They were within the specified as per the male and female and age group. I could see that not much of variations were seen, and majority of the patients they were suffering only from hypokalemia, but 13 patients were also suffering from associated diseases, associated areas like bleeding, blurring of vision, and others as it is given. Then if you see severity analysis, majority of the patients, like up to out of 60, 50 patients were suffering from mild to moderate hypokalemia, and 7 were suffering from severe, and 3 patients data was not available, like serum potassium levels were not available, so they were excluded from analysis. And 47 were considered as SAE based on the definition of SAE, remaining were not considered as SAEs. So coexisting diseases, if you see, single disease was suffered by 29 patients, and more than one disease was suffered by 31 patients, and average was 2.05 diseases were suffered by the patients. Number of organs involved, single organ system was involved in 32 patients, and multiple organs were involved in 28 patients. If we come back to the respiratory diseases, 38 patients were suffering from respiratory diseases. These are the diseases that are displayed here, like chronic obstructive disease, chronic obstructive pulmonary disease, breathing difficulty, lower respiratory tract infections, like that. And if you see here, number of drugs used was like only one drug was used in one patient. Remaining patients were on multiple drugs, like 59 patients had multiple drugs used, and average number of drugs used were 4.4. It means that polypharmacy was very relevant. And then overall, if you see, pantoprazole was used in most of the patients, levosalbutamol and furosemide, they were also used in the treatment. So coming back to the anti-asthmatics here, levosalbutamol, ipratropium bromide, salbutamol, levosalbutamol were considered as the causative agent for hypokalemia in respiratory diseases. So now coming to the reasoning, if you see here, like bronchodilators like beta-2 agonists and xanthines, they can do the inward shift of the hypokalemia through the sodium potassium ATPase. In that way, they produce corticosteroids. They increase the loss of potassium in the urine. So in that way, they increase the loss. So one need to be careful when they are using these drugs. Respiratory diseases and if you consider the respiratory diseases, 5% of the patients already suffering from hypokalemia if they are suffering from COPD, and reasons are they will have inappropriate secretion of ADH already, and they will be suffering from other diseases also like cardiovascular diseases, and they may have to use some cardiovascular diseases drugs, and they will also produce hypokalemia, and volume reduction need to be done. In that way, we may use diuretics. So in that way, there are chances that patients will suffer from the hypokalemia. So conclusions, like all the conclusions what I have made is based on the literature. Individual patient attention need to be drawn, and we need to consider evaluating clinically. And then conclusion is hypokalemia can result in dead end, means they can trouble the patients. One need to be careful. Drug disease interaction need to be considered. And when I presented to the clinicians, they really appreciated our work. They wanted to, this kind of support from the pharmacologists. And also we can use the technology like artificial intelligence, computer triggered, reminders to prevent the adverse drug reactions and then help the patient.
Any questions from the audience? So was causality assessment done?
Yes, ma'am. WHO causality assessment was done. And as I mentioned here, if you see here, 38 patients were suffering from respiratory diseases, but 22 patients were considered to be due to the drugs used for treating respiratory drugs. So even though 32 patients were using levosalbutamol and derifilin, salbutamol, budesonide, but here you can see 22 patients, they were only considered as the causative agent for the hypokalemia. Among them, out of 32, only 22 patients were considered to be suffering from hypokalemia due to the respiratory drugs.
No, what if it is WHO causality which was done?
Yes.
These were the 22 patients in which you think it was likely?
Likely, probably likely.
So it was a retrospective study. You have started from hypokalemia and you have gone to research whether it was related to disease or drugs.
Yes.
So why did you choose this respiratory disease rather than GI disease or cardiovascular disease?
Madam, actually I have done the complete study, including all the diseases like diabetes, anti-diabetes.
What was your place of study?
I have done, but since I have only given here only 5 minutes, I have only concentrated on the respiratory diseases related.
Why did you choose the respiratory disease only?
Because among all these, 38 patients were suffered. Out of 60, 38 patients were suffering from respiratory diseases. That's why I considered, I think this is more appropriate to present here. But I have done a complete study including GI diseases, respiratory diseases, or diabetic patients. So even insulin can also produce hypokalemia due to inward shift again. So like that I have done. Pantoprazole, actually I saw that majority of the patients were almost out of 60 patients, 37 patients were using
Chronic diarrhea patients, vomiting patients.
If you see, 37 patients was using pantoprazole, but this was not considered to be the causative agent for hypokalemia. But I tried searching literature, and I found that in extreme cases there is like pantoprazole can also induce hypokalemia when in a compromised patient. Yes, sir. If you see here, sir, what I said that respiratory lung diseases, they have a chances that they will be suffering from inappropriate secretion of ADH, SIR. So that's why I used. So actually, my sample size was only 60. So in that, I could see a few patients who are suffering from respiratory diseases like this. You can see here, like only 17 patients, 5 patients, 4 patients, like that. So I tried clubbing together, and when I searched in the literature, I could find why these I wanted to give the heads up to the clinicians, saying that like when a person is developing the hypokalemia, there are chances that body should be ready already to get into that severe or mild to moderate hypokalemia. So disease, if they are suffering from these diseases, body is already getting ready to have some kind of hypokalemia, and on the top of it, once you start giving the drugs, there are chances that it will come out as a clinical sign or symptom, and patient may experience. That's why I want to give the message to the clinicians, saying that if the patients are suffering from these diseases, be aware that there are chances that patient is already getting into that mode of hypokalemia, and when you add these drugs, there are further chances that they will get into the severe mode of hypokalemia.
No.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yeah, sir. Sir, these drugs like